The neurological examination of the normally awake neonate is the first step in the process of mastering neonatal neurology. The purpose of the neurological examination in neonates is to evaluate the central and the peripheral nervous system. This is accomplished by crisscrossing these systems in all areas such as the brain, the spinal cord, or the lumbosacral plexus. The crisscrossing of these structures allows us to determine the function or dysfunction of their components. The neurological examination of a neonate should be conducted without unduly disturbing the neonate. The goals of the neurological examination are four. First, to detect or exclude neurological abnormalities. Second, to arrive at an anatomical localization. Anatomical localization is an important step in the evaluation of every neurological finding. Anatomical localization may help us ascertain normalcy by documenting the functional integrity of an anatomical area, or anatomical localization may assist us by diagnosing pathology by demonstrating dysfunction at a given area. I encourage you, for more details on this subject, to see the YouTube video An Approach to the Neonate with Neurological Findings. The third goal of the neurological examination is to gauge neurological maturity. Gauging neurological maturity is not a mean to determine the duration of pregnancy, but a way to determine if the neurological development has progressed as expected during pregnancy and after delivery. Gauging neurological maturity is important for many reasons, not the least of them being not to misjudge a neurological finding appropriate for age as an abnormality. So, for the reason we have just given, not to misjudge a neurological finding appropriate for age as an abnormality, the age of the neonate at the time of the examination is important and it should be qualified. In order for us to qualify age, we need to understand a few age-specific terms related to pregnancy. In this frame, if you have a good imagination, you can see a uterus. Next to it, you can see another uterus with some red drops under it. The red drops are there to indicate bleeding. The arrow pointing to number 1 in the calendar indicates the first day of the last menstruation prior to delivery. Bleeding usually stops 3 to 5 days after it starts. The third uterus and the new calendar above it, with numbers 8 through 14, indicates the second week after the bleeding started. Hence, we refer to the time between the 8th and the 14th day after the onset of bleeding as the second post-menstrual week. It is usually at the end of the second week, at about day 14 after the first day from the last menstrual period, that the ovum is fertilized. The fourth uterus corresponds to the third week. The third week includes day 15 to day 21 after the first day of the last menstrual period. For the purpose of explaining the definition I am about to introduce to you, we are going to establish that delivery takes place 40 weeks after the first day of the last menstrual period. The next calendar indicates week 42 and the next week 44. For the purpose of our discussion, we are going to set the 44th week as the week the patient is being evaluated. Please take a few seconds to review this cartoon because the points just mentioned are vital for us to understand the terms we're about to define. The first of these terms is gestational age. Gestational age is defined as the time spent between the first day of the last menstrual period and delivery. The gestational age of a full-term neonate is from 37 weeks to 41 weeks and 6 days. In this example, the gestational age is 40 weeks. If we consider that in this case we are seeing the patient 4 weeks after birth, then we will consider that the chronological age is 4 weeks. Chronological age is also called legal age. It is the age from the time of birth till the time the patient is being seen. In the next example, we will consider a neonate with a gestational age of 38 weeks with a chronological age of 6 weeks. I chose this example to introduce the definition of corrected age. Corrected age is defined as the age a patient would have had if the patient would have been born at 40 weeks. Hence, in the example given, the corrected age is 4 weeks. Another important definition is postmenstrual age. Postmenstrual age indicates the total number of weeks from the first day of the last menstruation to the chronological age of the patient, regardless of the time of birth. In both of our examples, that is, in the first example, when the patient was born at 40 weeks and evaluated at 4 weeks of age, and in the second example, when the patient was born at 38 weeks and evaluated at 6 weeks, the postmenstrual age is the same, 44 weeks. The final term I would like to introduce is conceptional age. Conceptional age in a natural pregnancy is estimated by subtracting 2 weeks from the postmenstrual age. The 2 weeks are subtracted because it is 2 weeks after the first day of the last menstrual period when the ovum usually becomes fertilized. The conceptional age is precisely known with artificial insemination. Hence, in this group, we do not usually talk about postmenstrual age. But if we were to use the term postmenstrual age, we would add 2 weeks to the precisely known conceptional age. During this talk, despite the difficulties that arise from reviewing the literature based on the different terminology used, age is given as postmenstrual age unless otherwise stated. Postmenstrual age is preferred because in most instances the timing of birth has less influence in the neurological exam than the passage of time. And the fourth and last goal of the neurological examination is to craft a neurological examination report. The neurological examination report should be written in such a way as to help healthcare professionals to communicate among each other. The final product of a neurological examination is the neurological examination report. The neurological examination report in a normal neonate should be unambiguous and brief. As you can see, the backbone of the report, highlighted in yellow letters, does not depart from what we learn in medical school. But what departs from what we learn in medical school is the duration of the comments. Mental status is described with about 5 words. One of these words is normal. Comments on cranial nerves usually omit the first nerve and are brief for all others. Comments on the motor exam are restricted to writing that extremities move well and postural and dynamic tone are normal. Comments on the sensory examination just states that reaction to touch is good, cerebral function is described as normal, and at the end, the impression is just 4 words: normal for post-menstrual age. Normal in the context of the neurological examination of the neonate implies to me the absence of a significant abnormality. I classify abnormalities as absolute and relative. I use the term of absolute abnormality to refer to a finding that renders the neurological examination abnormal, even if it is the only sign present in the neurological exam that deviates from normalcy. Absolute abnormalities are always significant. Relative abnormalities are only significant in 2 situations. The first situation is when they occur in association to other findings indicative of pathology at the same anatomical location. The second situation is when they support a clinical impression. Relative abnormalities are not significant if they occur as the only finding indicative of pathology at an anatomical location, or if not supported by clinical impression. Relative abnormality is a mind term that I use almost exclusively when judging maturation of findings. This term should not be used in the neurological examination report. A few specific examples that I will provide as the talk progresses will render this point clearer. Now, looking back to the neurological examination report, I would like to mention 2 points. The first point is that during the course of this talk, I will be pointing out to you how the different items examined contribute to crafting the neurological examination report. The second point is that despite the brevity of the neurological examination report, in a normal neonate, this talk will be long and convoluted. It is convoluted because determining what is normal in a neonate is not always easy. 3 factors makes it so. First, maturational variability. Frequently in neonates, isolated maturational delays of as much as 4 weeks are present and then in a short period of time disappear, leaving no apparent ill effects. Should, if an exam is performed while the findings suggestive of such maturational delays present, be labeled abnormal? Second, conflicting neurological findings. Frequently, in neonates, information about the same item gathered from different perspectives during the neurological examination contradict each other. For example, as I will explain later in more details, postural tone is assessed by resting posture and passive range of motion. So, if the resting posture of a 40-week postmenstrual age neonate is typical for a 34 postmenstrual age neonate, but the passive range of motion coincides with the neonate postmenstrual age, how should postural tone be judged, normal or abnormal? And the third confounding factor is the staggering depth, pace, and frequency of clinical variations present in a normal neonate within a 24-hour cycle. You may examine a neonate at one point in time and find abnormal muscle tone, and 30 minutes later, the abnormality is gone. Was the abnormality due to a transient ischemic event or just a stage-dependent finding? To help me unravel the complexity generated by these factors, I will introduce to you a friend of mine. I call him the inquisitive monkey. He will, on my behalf, introduce many questions that I will use to drive the flow of the discussion to as narrow a path as possible. The first of such questions is, when is the best time to examine a neonate? The best time is 1 hour before the next scheduled feeding. The neonate must be awake at the time of the exam, or if asleep when first seen, the neonate must be awakened. The next question I will have my friend ask you is, what is the best position to examine a neonate? The answer is when the neonate is laying supine with the head and trunk aligned. Head-trunk alignment avoids a normal primitive reflex present during the neonatal period called the asymmetrical tonic neck reflex. This primitive reflex, initiated by sustained passively or actively sideways turning of the head, consists of extension of the arm and to lesser extent of the leg on the side the face is turned towards, and flexion of the opposite limbs. This position is often referred to as fencing posture. The presence of this reflex is relevant because the only time an asymmetrical motor finding is normal in a neonate is when the asymmetry is provoked by this reflex. Otherwise, any asymmetry in the motor exam is an absolute abnormality. The third question we must ask ourselves is, how can we perform an examination? Unavoidably, the answer to this question will be personal and time sensitive. This is so because every neurologist has a particular way of ordering the steps required to assess the nervous system of a neonate, and because every neurologist is subject to change the way they do the exam at any time based on changing personal preference or circumstances surrounding the patient. So, I will tell you one way of doing the neurological examination and documenting it. Certainly not the only way, maybe not even the best way, but what can I say, other than it is the way I do it, at least for now. My approach to the neurological exam is to divide it in two segments. The first of this segment I call Gestalt. I will spend a few minutes talking about this segment now. The Gestalt segment of the neurological examination consists of looking at the neonate in a global manner. During this segment, I look for findings that may steer the neurological exam in one or another direction, such as malformations, deformations, and muscle bulk abnormalities. During this segment of the neurological examination, I also consider three items that contribute to the overall assessment of the neurological examination. The first of this item is resting posture. Resting posture, the action of gravity upon the neonate when the neonate is in supine position not attempting to move, should be analyzed in relation to postmenstrual age. In this frame, the numbers in line with the calendar indicate postmenstrual weeks. At 28 postmenstrual weeks, the neonate will have no significant motor tone, and the position of the legs and the arms are dictated by the geometry of the skeletal system. At this age, arms and legs are extended. At 30 weeks, minimal leg flexion will appear, while the arms will remain extended, but they are usually slightly more separated from the trunk than they were at 28 weeks. At 32 weeks, the neonate will have some knee and hip flexion. The arms will remain primarily extended, but a flicker of flexion may be noted at the elbow. At 34 weeks, the neonate will have a stronger knee and hip flexion. At this stage, the predominant posture tone of the legs produces a typical position. This position is called the frog leg posture. The arms at 34 weeks show some flexion at the level of the elbow. At 36 weeks, knee and hip flexion will be very pronounced, and for the first time, the lateral aspect of the thigh will be off the mattress, the latter signaling the beginning of adduction of the legs. The arms will be flexed at the elbow at 36 weeks. At 38 weeks, flexion and adduction of the lower limbs will be even stronger than they were at 36 weeks. The arms will also be strongly flexed at the elbow. The increasing flexion tone of the forelimbs present at this point is such that the term hypertonia is often used to describe the tone of neonate in this age group. I do not like to use this term because in my mind, hypertonia implies abnormality, which is certainly not the case in these patients. By 40 weeks, the neonate will have a very typical posture. When looked from the side, the legs will be adducted in addition to being flexed. The arms are lifted from the mattress. The hands are usually fisted. Only the heels, the buttocks, the scapular region, and the occiput will be touching the mattress. The evaluation of the resting posture gives us an idea of the status of the corticospinal functional system. The neurological structures involved in this functional system include the brain, midbrain, the pons, the medulla, the cerebellum. The cerebellum, as well as the corpus striatum, influence the corticospinal tract by the rostral connections. Continuing enumerating the structures that influence the corticospinal tract, we have the spine, neck, muscles and nerves, arms, muscles and nerves, trunk, muscles and nerves, and legs, muscles and nerves. It would be easy to gather from the previously described link between resting posture and postmenstrual age that any deviation from it implies a significant abnormality, but in my opinion, this is not so. I use 6 weeks maturational delay to indicate an absolute abnormality, hence a significant abnormality. Such would be the case, for example, of a neonate born with a gestational age of 40 weeks, examined at the chronological age of 2 days, that instead of the resting posture typical for the neonate postmenstrual age has the resting posture of a 34 week. On the other hand, a delay of less than 6 weeks but more than 2 weeks I consider a relative abnormality. For example, if the same neonate examined in similar circumstances has the resting posture typical for a neonate with a postmenstrual age of 36 weeks, I label such finding in my mind as a relative abnormality. Finally, I do not consider a maturational delay of 2 weeks or less as an abnormality. To give you an example, again, if a neonate born with a gestational age of 40 weeks, examined 2 days after birth, has a resting posture of a 38-weeker, I do not consider it an abnormality. I use the same parameters I just used to judge the status of the resting posture of the neonate to judge other maturational findings. Hence, if the neurological finding reflects a maturational delay of 6 weeks, I call it an absolute abnormality. If the neurological finding reflects a maturational delay of more than 2 weeks but less than 6 weeks, I think of it as a relative abnormality. And if the neurological finding reflects a maturational delay of 2 weeks or less, I classify it as normal. Now, going back to the subject of resting posture, we can ask ourselves, how does the evaluation of the resting posture contributes to a neurological examination? The evaluation of the resting posture contributes, as we previously stated, by adding to our final assessment of the postural tone. And the assessment of the postural tone will be reflected in the crafting of the neurological examination report. After evaluating resting posture, and still while conducting the Gestalt segment of the neurological exam, I check behavioral appearance. Evaluation of behavioral appearance contributes to the analysis of mental status. Mental status has 2 components: arousal, and content of consciousness. Arousal is best correlated with eye appearance. During an arousal, the eyes are open and brisk conjugate eye movements are present. Arousal is judged by the forcefulness of the stimulus required to wake the patient up, and by the duration of wakefulness once it is achieved. Arousal is greatly influenced by timing in relation to feeding, room temperature, and by post-menstrual age. Attempting to describe the amount of stimulus required to wake a neonate is not helpful. Suffice to say that we all know how much is the right amount when we see it. On the other hand, a qualitative description of the duration of arousal is possible. At 26 weeks, arousal is unsustainable. The 20th edition of Nelson's textbook of pediatrics states that premature infants born at less than 28 weeks of gestation do not have consistent arousal. I assume that they are referring to neonates during the first days of extrauterine life. At 30 weeks, arousal is briefly sustained. At 34 weeks, arousal is sustained during a significant amount of time, certainly enough to conduct a neurological examination. After assessing arousal, the next step in the evaluation of behavioral appearance is to analyze the neonate's content of consciousness. I evaluate the content of consciousness by analyzing alertness to visual stimuli, irritability in response to stimuli, and consolability. Judging mental status is easy in a full term at the extreme of behavioral spectrum. Judging mental status with certainty in premature neonates and in those full terms in the neutral zone between bushy tail and comatose is not as easy, and careful judgment and observations at the beginning and at the end of the exam period are often needed. In my opinion, a normal neonate after 36 weeks should be expected to arouse easily and to sustain arousal during the whole exam, and in addition, to make good eye contact, to cry when stimulated, and to calm down when soothed. After 40 weeks, in addition to the accomplishment we have just mentioned, the neonate will fixate briefly and follow an object if directly in the neonatal path of vision for a short distance. Although we usually consider fixating and tracking as part of the mental status evaluation and therefore evaluation of the brain function, it is possible that the sensory pathway used at this age for tracking does not include the lateral geniculate in the thalamus and the occipital pole in the cortex, but the pulvinar nucleus in the thalamus and the superior colliculi in the brainstem. The question regarding the areas surveyed during the evaluation of behavioral appearance is difficult to answer with any degree of certainty. The most likely area being evaluated during behavioral assessment is the core region of the upper pons and midbrain and the diencephalic regions. Whether in addition we are testing the cerebral cortex or the midbrain tectal region is uncertain. As we have previously inferred, the evaluation of behavioral appearance contributes to the neurological exam by providing information regarding mental status. Behavioral appearance is the major factor in asserting that arousal is normal and contributes significantly to concluding that the neonate is alert and interactive. Once I conclude evaluating the behavioral appearance of the neonate, and still during the Gestalt segment of the examination, I do the sensory examination. Sensory examination in the neonate is limited to observing changes in behavior when the patient is touched. I start by gently stroking the dorsal aspect of the feet. The dorsal area of the foot is innervated by the fifth lumbar and the first sacral spinal segments. Next, I stimulate the hands by gently rubbing the dorsal thumb region, an area innervated by the radial nerve, then over the thumb's palmar regions, an area innervated by the median nerve, and then I touch the little finger, an area innervated by the ulnar nerve. The spinal segments involved in sensory perception of the hand are the cervical spinal segment 7 and 8. Finally, I check the trunk. In the trunk there are two landmarks, the nipples, which correspond to the fifth thoracic spinal segment, and the umbilicus, that corresponds to the 10th thoracic spinal segment. The sensory evaluation is incorporated in the neurological report in the mental status section. Arousal in a normal neonate is usually produced by gentle touch of the distal extremities, and in all cases produced by gentle rubbing of the trunk. Sensory examination also has its own section. In it, I just mentioned that reaction to touch was good. After looking for major malformations and deformities, checking muscle bulk, and analyzing resting posture, behavioral appearance, and sensory examination, that is, after completing the Gestalt segment of the neurological examination, I start the second segment of the neurological examination, which I call regional. I used to begin the regional segment of the neurological examination by evaluating the leg region, but now, most of the time, I start by evaluating the facial region. During the examination of the facial region, I attempt to address enough items to cover all the cranial nerves and to answer three basic questions. The first question is, which pathway is involved? I think knowing the anatomical pathway is particularly important in the facial region because the area evaluated are often sites of pathology. The second question is how to perform the actual evaluation, and the third question is what constitutes normalcy. The first item I evaluate in the facial region is the pupillary system. The pupillary system is involved in light perception and the pupillary reflex. The pathways involved are the optic nerve, the Edinger-Westphal nucleus, the third nerves, ciliary ganglia, short ciliary nerves, and the pupillary sphincters. Light perception and pupillary reaction are checked one eye at a time. The room ambient should be rather dark. You can use a flashlight or an ophthalmoscope, but the light should be soft. A bright light will provoke shutting of the eyelids, thus preventing you from looking at the pupils. The light is shined into one pupil and then the other. Normalcy is best established by observing the size of both pupils before shining the light. When one pupil is exposed to the light, both pupils contract symmetrically and simultaneously. The pupillary light reflex is not present before the 28th week of postmenstrual age, may or may not be present between week 29 and 31, and is present after the 32nd postmenstrual week. I consider the absence of bilateral pupillary reflex after 32 weeks as an absolute abnormality. After evaluating the pupillary system, I usually check the eyelid system. Eyelid movements result from the interplay of three muscles. In the next few frames, I will describe these muscles and their connections. I will start with the levator palpebrae. The function of the levator palpebrae is to raise the upper eyelid. The levator palpebrae is innervated by the third cranial nerve. The origin of the fibers for the levator palpebrae is a single subnucleus of the third cranial nerve nucleus located in the midline upper midbrain region. This subnucleus innervates both levator palpebrae. This nucleus receives impulses from the cerebral cortex, but not directly. The next muscle to consider is the orbicularis oculi. The function of this muscle is to bring the upper eyelid down and the lower eyelid up, thus shutting the eyes. This muscle is innervated by the zygomatic nerve. The zygomatic nerve is one of the upper branches of the seventh cranial nerve. The nucleus of the upper branches of the seventh cranial nerve is in the ipsilateral pons. This nucleus receives cerebral cortical fibers from the contralateral and the ipsilateral hemispheres. The last eyelid muscle to consider is the muscle of Mueller, or as it is often called, the superior and inferior palpebral tarsal muscles. The muscle of Mueller raises the upper eyelid and brings down the lower eyelid, thus widening the eye opening. The muscle of Mueller is innervated by postganglionic sympathetic fibers arising from the superior cervical ganglion. These fibers ultimately reach the muscle of Mueller by hitching a ride with the ophthalmic division of the fifth cranial nerve. The preganglionic sympathetic neurons innervating the superior cervical ganglion originate from the nucleus of Bulge in the first thoracic spinal segment. The nucleus of Bulge receives fibers from the hypothalamus. The integrity of these structures are evaluated by observing the position of the upper and lower eyelids in relation to the iris, and by estimating the force required to open the eyelids when they are closed. Most infants, if observed long enough, will spontaneously close their eyes. When this is not the case, I like to use a bright light to provoke eyelid movements. I like to use light since I have already checked the integrity of the visual pathways by the pupillary reaction. Normalcy is indicated by the position of the eyelids in most fully awake neonates. This position is rather stereotypic. The upper eyelid is just above the upper pole of the iris, while the lower eyelid covers the lower pole of the iris slightly. The eyelid movements of both eyes should be synchronous and symmetrical when being open and when being closed. Once the eyes are closed, the force required to open them is rather significant. An interesting finding is that by 26 weeks of postmenstrual age, neonates will blink continuously as long as the bright light is on their eyes, whereas by 32 weeks of postmenstrual age, the eye of a neonate will remain closed as long as the bright light is on their eye. After examining the eyelid system, I examine the gaze system. The pathways involved in extraocular movements are rather complicated. I'd like to start by telling you about the third cranial nerve. This nerve innervates four extraocular eye muscles: the inferior oblique, the medial, inferior, and superior recti. It is worth noticing that the innervation of the superior rectus arises from the third cranial nerve nucleus in the contralateral side. It is also worth noticing that the fibers from this nucleus travel through the opposite third cranial nerve nucleus on the way to the superior rectal muscle. This peculiar innervation is important because bilateral superior rectal weakness may indicate unilateral midbrain lesion. The fourth cranial nerve innervates the superior oblique muscle. The nucleus of the fourth cranial nerve has two peculiarities. It provides fibers for the contralateral fourth cranial nerve, just as the superior rectus subnucleus of the third cranial nerve did. But in addition, the fibers exit through the back of the brain stem. The next cranial nerve that we should consider is the sixth. The sixth cranial nerve innervates the lateral rectus. Two other structures are very important in the understanding of extraocular eye movements. One of these structures is the parapontine reticular formation. The parapontine reticular formation is represented in this frame by the blue sphere. The parapontine reticular formation receives impulses from the contralateral hemisphere. The contralateral innervation for the parapontine reticular formation comes from the frontal lobe of the brain. The parapontine reticular formation also receives innervation from the ipsilateral hemisphere. In this case, the ipsilateral hemisphere connections arise from the occipital lobe. These connections are not represented in this drawing. The other important structure to consider is the medial longitudinal fascicle. This structure connects the contralateral sixth cranial nerve nucleus with the ipsilateral third cranial nerve nucleus. Another brain stem structure important to the understanding of eye movements is the eighth cranial nerve and its connection with the vestibular apparatus in the inner ear. I evaluate the gaze system by simply observing the neonate. If you spend long enough looking at a neonate, sooner or later the neonate's eyes will move laterally to one side and then to the other. I have hardly ever seen a normal neonate look up or down. When after a while I do not see any eye movements, I use the Doll's maneuver to induce them in the neonate. The Doll's maneuver consists of holding the eyes open and moving the head side to side while observing the eye movements. Orienting the head 30 degrees angle above the mattress while doing this maneuver is recommended. Another way to evaluate eye movements in neonates is holding the neonate up by the trunk with about a 30-degree tilt forward and swinging the neonate around as indicated by the arrow. This maneuver is often referred to as the modified Doll's maneuver. Normalcy is indicated by smooth conjugated movements of both eyes. The conjugated movements are easily noted when they occur spontaneously. When instead of occurring spontaneously, a maneuver is required to generate them, the direction and extent of the movements are less obvious. During Doll maneuver, when the head is moved or turned to the left, the contraction of the right lateral rectus and the left medial rectus causes the eyes to look to the right. If at this point the head is turned to the right, the contraction of the left lateral rectus and right medial rectus will cause the eyes to briskly turn to the left. This movement, from the perspective of the examiner's viewpoint, translates to no apparent eye movements. It was from the appearance of the lack of eye movements that this maneuver was named the Doll's maneuver. In the old days, the eyes of the dolls were made of plastic spheres with more weight fixed at the opposite side to the painted iris. This way, the bottom of the sphere, driven down by its weight, will always keep the iris looking straight when the doll head was moved from side to side. This reflex is usually present after 25 weeks of post-menstrual age. Those eye responses are not present in normal older patients. The length of time they are present after birth is debatable. It is said by some authors that the eye movements triggered by the Dolph maneuver are present in full-term neonates only during the first 2 weeks of life, whereas other authors have reported those eye responses to persist during the neonatal period. I judge the consistent absence of eye movements during Dolph's maneuver in the first week of extrauterine life as a relative abnormality. I judge the consistent absence of eye movements during Dolph's maneuver after the first week of extrauterine life as a normal finding. The normal response to the modified Dolph's eye maneuver is for the eyes to deviate tonically towards the side of the swing as long as the swing is going on, and a coarse nystagmus to occur in the reverse direction once the swing stops. The nystagmus is not shown in this cartoon. I do not use this maneuver to gauge maturity. I use it to detect extraocular eye movement abnormalities. After evaluating the case system, I evaluate facial sensation and consider testing smell. The pathways involved in facial sensation start in the different cutaneous sensory receptors spread over the face. Information is collected by 3 branches of the trigeminal nerve whose bodies are in the trigeminal ganglion. From the trigeminal ganglion, fibers enter the pons to end at the principal sensory nucleus of the trigeminal nerve and the nucleus of the spinal tract of the trigeminal nerve. From these nuclei, information travels to the thalamus and ultimately to the cerebral cortex. I evaluate facial sensation by blowing air into the neonate's face or by touching different areas that correspond with the different branches of the trigeminal nerve and seeing what the reaction of the neonate is. Normalcy is indicated by eye closure or change in behavior coinciding with the stimulation. Eye closure should be bilateral, even with unilateral facial stimulation. The pathway involved in smell is a tract that extends to the nose. This tract is at the base of the cerebral frontal lobes. I evaluate smell by approximating a Q-tip bathed in peppermint extract or in mother's milk. Normalcy is indicated by closing the eyes when exposed. It has been reported that exposure to peppermint extract after 32 weeks of gestational age leads to behavioral change in all normal neonates. The last method of checking smell is to expose the neonate to a Q-tip bathed with mother's milk. In this case, the neonate responds by turning the head towards it. Before dropping the subject of smell, it has been said that neonates with postmenstrual age of 28 weeks can smell and that smell can be reliably tested after 32 weeks. I do not check smell routinely because I have found the results of testing inconsistent even in the same patient. After evaluating facial sensation and smell, I evaluate neck and tongue movements. The pathways involved in neck and tongue movements are at the level of the lower brainstem and the upper cervical spinal cord, thus involving structures just above and below the foramen magnum. Among these structures are the principal sensory nucleus of the trigeminal nerve and the nucleus of the spinal tract of the trigeminal nerve. From these nuclei, fibers cross to the opposite side while going below the foramen magnum to reach the accessory nucleus in the upper cervical spine. Fibers from the accessory nucleus re-enter the skull through the foramen magnum and then send fibers that traveling through the jugular foramen reach the sternocleidomastoid muscle. In addition, fibers from the trigeminal nuclei also cross the midline to reach the hypoglossal nucleus. Fibers from cranial nerve 12 innervate the hemitongue musculature. Left sternocleidomastoid muscle contraction turns the head towards the right. Left hemitongue muscle contraction turns the tongue towards the right too. Neck and tongue movements are evaluated by observing spontaneous tongue movements to one side and to the other. Tongue movements can also be provoked by stimulating the side of the mouth. Stimulating the side of the mouth provokes the rooting reflex. Normalcy is indicated by observing spontaneous symmetrical movements to one side and to the other. Normally, there is no consistent deviation of the tip of the tongue to either side. In addition, when stimulation of the side of the mouth is used to provoke tongue movements, we can also evaluate the neck muscles. In these cases, turning of the tongue will occur simultaneously with turning of the head. They both turn towards the stimulated side. As just stated, this reaction is called the rooting reflex. This reflex is present consistently since about 34 weeks and may persist up to 56 weeks. It disappears first in the wake state and later in the sleep state. At 40 weeks, almost all neonates have a full rooting response, although in a few of these neonates, the reflex is inconsistent. After evaluating the neck and the tongue, I consider checking the gag reflex. Most of the time, the way I evaluate this reflex in neonates differs from that of the way that they are evaluated in older patients. This difference stems from the fact that it's very difficult to visualize the soft palate and the uvula in neonates, and in addition, it causes the neonate a certain degree of stress. Hence, often I restrict the evaluation of the gag reflex to the sensory arm of this reflex by judging its integrity in relation to eye closure. The pathway involved in the gag reflex uses two nerves, the glossopharyngeal nerve and the vagus nerve. Sensory information from the posterior pharynx is relayed to the pharyngeal branches of the glossopharyngeal nerve, to the principal sensory nucleus of the trigeminal nerve, and the nucleus of the spinal tract of the trigeminal nerve. Fibers from these nuclei remain on the same side and contact the nucleus ambiguous. The nucleus ambiguous sends fibers to the soft palate through the glossopharyngeal nerve via the cranial nerve component of the accessory nerve to innervate the elevator belly palatine, and through the vagus via the pharyngeal branches to innervate other pharyngeal muscles involved in the gag reflex. Contraction of the elevator belly palatini elevates the soft palate and the uvula. Gagging is evaluated by pharyngeal stimulation. The normal response to stimulation of the posterior pharynx is grimacing, that includes blinking, and elevation of the soft palate and the uvula. The elevation of these structures is a function of the 9th and 10th cranial nerve. Palate and uvula elevation evaluates the motor arm of the gag reflex. After considering checking or actually checking the gag reflex, I evaluate the pouting system. The anatomical pathways involved in the pouting system include the lower facial muscles of expression, including the depressor angularis oris, cranial nerve 7, the facial motor nucleus, and the fibers arising from the contralateral lower region of the motor cortical strip. I evaluate the pouting system by observation of spontaneous activity or by provoking lower facial movements by tactile stimulation of the face or by pharyngeal stimulation. Normalcy is indicated by symmetrical deepening of the nasolabial fold, rising of the upper lip, and symmetrically lowering of the lower lip. Another way to assess lower facial movements is by observing the neonate feed. While feeding, the lips should seal the nipple of the bottle, avoiding any leakage. After evaluating the pouting system, I evaluate hearing. The anatomical pathways involving hearing are a little bit complicated. The first structure that we need to know about is a spiral ganglion, which is located in the cochlea. Then comes the eighth cranial nerve, the cochlear nuclei, the trapezoid body, the lateral lemniscus, the inferior colliculus, the brachium of the inferior colliculus, the medial, the acoustic radiation, and the auditory cortex. The integrity of this structure is vital for normal hearing. Sound that gets translated into electrical activity at the level of the cochlea is transmitted throughout the system, ultimately arriving at the auditory cortex. I evaluate hearing by clapping and watching facial reactions. Normalcy is indicated by observing a change in behavior, especially eye closure, coinciding with the clapping. After hearing, I check feeding. The pathways involved in feeding spread through a large territory of the nervous system. Feeding is by far the most complex of all neonatal endeavors. Feeding integrates three functional systems: sucking, swallowing, and breathing. The cranial nerves involved with feeding are those used for sucking, which include the muscles of mastication, innervated by the motor component of the trigeminal nerve. The motor nucleus of the trigeminal nerve is in the pons. Its fiber leave the brainstem and join the third branch of the trigeminal nerve, thus reaching the masticatory muscles. They are in this frame represented in green. Sensory information regarding the degree of stretch in the masticatory muscles is carried back to the brainstem by the trigeminal nerve. The body of the sensory nerve neurons carrying this information are not in the trigeminal ganglia, as other sensory components of the trigeminal nerve are, but they are in the mesencephalic nucleus of the trigeminal nerve. This nucleus is in the upper pons and lower mesencephalum. The muscles of mastication are tested by checking the strength of the bite and by tapping the jaw. The force generated by these muscles can be felt by a finger introducing the baby's mouth. Tapping the jaw in a neonate usually produces 2 to 3 jaw contractions. The absence of such contraction is a relative abnormality. The other cranial nerves involved in sucking are the 7th and the 12th. These cranial nerves have been already discussed. In addition to sucking during feeding, we evaluate swallowing. 4 cranial nerves are used for swallowing. Motor component of the trigeminal nerve, fibers of the 9th that originally travel with the brainstem segment of the accessory nerve, fibers from the 10th cranial nerve, and fibers from the 12th cranial nerve. In addition, sucking and swallowing has to be coordinated with breathing. Breathing is carried out primarily by 3 nerves: the 5th cranial nerve, the 12th cranial nerve, and the phrenic nerve. Other cranial nerves, such as those involved in movement of the hyoid bone and the intercostal muscle, also contribute to breathing. I evaluate feeding by observing the neonate when the neonate is feeding, but often I rely on nurses' information to conclude that feeding is not an issue and to exclude feeding fatigue. Normalcy is indicated by strong suck, no leak, and no fatigue. The capacity to feed is certainly present by 34 postmenstrual weeks, but may be present as early as 28 weeks. With the evaluation of feeding, the evaluation of the facial region is concluded. The evaluation of the facial region contributes to the neurological exam by providing information regarding mental status and cranial nerve function. Next, after concluding the evaluation of the facial region, I evaluate the trunk and neck regions. Which areas are surveyed by neck and trunk evaluation? Neck and trunk evaluation surveys the corticospinal tract. In this frame, the corticospinal tract is depicted in blue and the muscles represented in brown. The structures here represented are the paraspinal muscles. The paraspinal muscles encompass multiple muscles that, as indicated by their name, are around the spine. In this group, we include the quadratus lumborum, the paraspinal nerves, the thoracic spine, and high lumbar spine. Areas of the spine where the sensory and motor tracts to the paraspinal muscles and the skin of the trunk are located. Neck muscles and nerve, including the sternocleidomastoid muscle and the accessory nerve, the medulla, the pons, midbrain, and the brain. Trunk and neck are evaluated by two maneuvers. These maneuvers are the neck traction maneuver. This maneuver consists of lifting forward the neonate by the hands while keeping the baby's butt on the blanket. The response to this maneuver is related to postmenstrual age. So, at 30 weeks, the head drops completely without any effort to raise it. At 32 weeks, the head still drops completely, but the neonate makes some effort to raise it. And at 38 weeks, the neonate managed to keep the head in line with the trunk for a few seconds and then drops it. The second maneuver I use to evaluate the trunk is the Gallant maneuver. This maneuver triggers a response in neonates older than 30 weeks postmenstrual age. It may be done with the neonate in prone position or during ventral suspension. This maneuver is here being performed with the neonate in ventral suspension. It consists of firm, sharp stimulation alongside the spine with the finger. This produces a contraction of the underlying muscles and curving of the back towards the site of the stimulation. The maneuver should be performed on both sides, and the responses obtained should be similar on both sides. How does the evaluation of the neck and trunk contributes to crafting the neurological exam report? Neck and trunk evaluation contributes to the crafting of the neurological exam report by adding to postural tone and sensory examination. Once the trunk and neck regions are examined, I evaluate the perineal region. The areas evaluated by the exam of the perineal region are the external anal sphincter, the pudendal nerve, and the second, third, and fourth sacral spinal segments. The method I use for perineal evaluation in neonate is observation. Normalcy is established by looking at the mucosal cutaneous creases irradiating from the anus. I also ask the nurses about the frequency of diaper change. The evaluation of the perineal region contributes to a neurological exam by providing information regarding the spinal cord. Findings from the perineal region are usually not included in the neurological exam report unless there is a question about dysfunction or if they are abnormal. After the evaluation of the perineal region, I evaluate the arms. The areas of the nervous system evaluated correspond to the corticospinal tract at different levels of the nerve axis. In this frame, the corticospinal tract is depicted in blue and the muscles represented in brown. As shown in this frame includes the muscles and nerves of the arm, and the spinal cord segment where the motor neurons that supply the arms are located. This structure is called the brachial eminence. In addition, we have the spinal cord, medulla, pons, midbrain, brain, and the cerebellum. The cerebellum influences arm movements by its connection with rostral structures. The arms should be evaluated by observation, provoked movements, confrontation testing, maneuvers, and by evaluating the musculotendinous reflexes. The evaluation of the arms will provide information about postural tone, force, and dynamic tone. Postural tone is evaluated by analyzing the resting posture and the passive range of motion. Resting posture was discussed previously. I will now address the issue of passive range of motion testing. The passive range of motion is evaluated by performing two maneuvers. One is the maneuver to elicit the scarf sign, and the other one is the maneuver to elicit the square window. The maneuver to elicit the scarf sign is done with the neonate supine. The infant's hand to be tested is held while the opposite hand is pulled down as if taking it to the opposite hip. Then, gently, the arm being tested is pulled around the neck as far posterior as possible towards the opposite shoulder. The distance the elbow can travel towards the opposite side will vary with postmenstrual age. At 28 to 30 weeks, the elbow passes the opposite anterior axillary line. By 31 to 32 weeks, it barely reaches the opposite anterior axillary line. By 33 to 34 weeks, the elbow reaches close to the mid-clavicular line on the opposite side. By 35 to 36 weeks, the elbow reaches the mid-sternal line, and by 40 weeks, the elbow reaches the ipsilateral mid-clavicular line. The second maneuver to evaluate the arm passive range of motion is the square window maneuver. The method to perform the square window maneuver is shown in this picture. Enough pressure is applied between the thumb and the index finger to approximate the hand to the forearm of the neonate. The square window maneuver produces two angles. The classically measured angle is between the hypothenar eminence and the ventral aspect of the forearm. We will refer to this angle as the anterior angle. My bias is to use the angle between the hypothenar eminence and the dorsal aspect of the forearm. I will refer to it as the posterior angle. These angles will vary with age. The variation is reversed. As the anterior angle gets smaller, the posterior angle gets bigger. At 32 weeks, the anterior angle is 90 degrees and the posterior angle is 270 degrees. At 36 weeks, the anterior angle is about 45 degrees and the posterior angle is about 315 degrees. By 40 weeks, the anterior angle is reported to be 0 degree, but in my experience it never is. It is usually in the range of 10 to 20 degrees, and the posterior angle is about 340 degrees. The relevancy of this process is that it indicates appropriate maturation, as I will explain to you in the next few frames. This set of frames depict the effect of time on passive range of motion. The two sand clocks indicate the time of birth. The first one indicates 28 weeks and the second one 40 weeks. The calendar on the left corner of the frame indicates the chronological age. In this example, 2 days of age. The drawings below the calendar represents the extensors of the humerus. As we have just described, when we spoke about the scarf sign, the extensors of the shoulder become more stiff with the passage of intrauterine life. In this frame, I am introducing the extensors of the wrist. The extensors of the wrist, which we have just evaluated by the square window maneuver, contrary to the extensors of the humerus, become more easily stretched as intrauterine life progresses. This course of event reflects central nervous system maturation. Healthy neonates born at 28 weeks gestational age will have similar extrauterine course as they would have had if they would have stayed in uterus. Hence, following the evolution of the shoulder and wrist passive range of motion are good parameters to evaluate maturation in premature neonates. In addition to postural tone, we must also consider force during upper extremity examination. Force is evaluated by determining the active range of motion and by confrontational testing. Active range of motion is evaluated by observing spontaneous movements or by observing the neonate after provoking arm movements. A simple place to provoke arm movements is tapping the glabella. For the evaluation of active range of motion, it's very important that the head be midline and in the same axis as the trunk. This position is important to avoid the normal asymmetrical posture triggered by the asymmetrical tunnel neck reflex, to which we have previously alluded when talking about the resting posture. In addition, several maneuvers can be used to combine the assessment of active range of motion and confrontational testing. Two of these maneuvers are the palmar grasp and the neck traction response. The neck traction response is the same maneuver we described while talking about the evaluation of the neck, but this time I will describe it with emphasis on the upper extremities. In the next few minutes, I will describe these two maneuvers in relation to postmenstrual age. I discuss them together because during the exam I do them simultaneously. The palmar grasp maneuver consists of putting the index finger into the hand of the neonate and gently pressing the palmar surface without touching the dorsal surface of the hand. We monitor during this maneuver finger movements. The neck traction maneuver is performed by holding the neonate by the wrists and pulling the arms upwards. During this maneuver, we should note the flexion of the elbow and the resistance of the shoulder as the neonate back is lifted. At 28 weeks, the grasp is incomplete and the arm remains straight. No resistance is felt at the shoulder. At 32 weeks, the grasp is complete and some elbow flexion is felt. Still, no resistance is felt at the shoulder. At 35 weeks, the grasp is complete and the elbow flexion is strongly felt. Contraction of the long head of the triceps pulls the arm towards the trunk. Still, no resistance is felt at the shoulder. At 37 weeks, the grasp is complete, elbow flexion is very strong, contraction of the tricep is also strong, and some shoulder resistance is felt. At 41 weeks, the grasp is complete, elbow flexion and tricep contractions are very strong, and so is shoulder resistance. After completing these two maneuvers, aimed at evaluating the arm, I proceed to elicit a motor response. The motor response can be triggered in many ways. Anytime the neonate feels the back is not being supported, a motor response will be triggered. The maneuver I often use consists of raising the neonate from the bed by pulling from the hands. If after lifting the head from the mattress I see no neck contraction, I bring the neonate back down until the occiput is firmly touching the mattress and then I release the arms. If, on the other hand, I feel good neck contraction, I keep lifting the neonate up, then After the torso of the neonate is off the bed, I bring the neonate down again until the occiput touches the mattress, and then I release the hands. As you can imagine, I include eliciting the motor response to the palmar grasp and neck traction maneuvers. The response to the motor maneuver is postmenstrual age dependent. At 28 weeks, the only noticeable reaction is the opening of the hand. By 32 weeks, in addition to opening the hand, the fingers will abduct, so the fingers will fan out, and the arms will go from the flexion position at the level of the elbows to extension. At 35 weeks, the arms from being extended will be abducted above the shoulders. At 37 weeks, the abducted arms will adduct and flex anteriorly, and the elbows will flex as if giving a hug. It is important that as these movements are going on, to be thinking about the structures involved in making them. During the next few minutes, I will name the actions, muscle, nerves, and spinal segments involved in palmar grasp reflex and neck traction response. I will do this in one table, and after, in a second table, I will also name the actions, muscle, nerve, and spinal segments involved in the motor reflex. I will use the same format for both. In the first column, as you can see, there is action, muscle, nerve, and spinal segment. The action depicted by the arrow is fisting. The muscles involved in this action are many. We will collectively call them the thumb and finger flexors and the palmar interossei. The nerves supplying these muscles are the median nerve for the radial side flexors of the hand and the ulnar nerve for the ulnar side flexors of the hand and the palmar interossei. The origin of these nerve fibers are from the 7th and the 8th cervical segments. The next action is elbow flexion. This action is accomplished by the biceps and the brachialis and the brachioradialis. The biceps and the brachialis are primarily innervated by the musculocutaneous nerve, the brachioradialis by the radial nerve. The muscles innervated by the musculocutaneous nerve are involved in elbow flexion when the forearm is supinated. The brachioradialis is primarily involved with elbow flexion when the forearm is mid-position between pronation and supination. The fibers for elbow flexion are provided by the 5th and the 6th cervical segments. The next action is adduction, that is bringing the arms towards the thorax. The most important of the abductors is the pectoralis muscle. The pectoralis are innervated by the pectoral nerve. The fibers for the pectoral nerve arrive from C5, C6, C7, C8, and T1. The next action is contraction of the shoulder girdle muscle. This action is achieved by contraction of several muscles: the pectoralis, the teres major, and the latissimus dorsi. The pectoral nerve innervates the pectoralis. The subscapular nerve innervates the teres major, and the thoracodorsal innervates the latissimus dorsi. The fibers for this nerve arises from C5, C6, C7, C8, and T1. Please take a moment to look at this table. You're welcome to pause the recording to do so. As you can see, this table represents the components of the upper extremities being evaluated by the combination of palmar grasp and neck traction response. I will now use the same format to name the actions, muscles, nerves, and spinal segments used during the motor response. The first action to occur during the motor response is extension and abduction of the fingers. This action is accomplished by the finger and thumb extensors and by the dorsal interossei. These muscles are innervated by the radial and the ulnar nerves. The fibers for these nerves arise from C7, C8, and T1. The next action that occurs during the motor response is elbow extension. Elbow extension is accomplished by the triceps. The triceps is innervated by the radial nerve. Fibers destined for the tricep traveling in the radial nerve arise from C6, C7, and C8. The next action is abduction of the arms. Abduction is carried out by the supraspinatus and the deltoid. The supraspinatus is innervated by the suprascapular nerve and the deltoid by the axillary nerve. The fibers for these nerves arise from C5 and C6. The next action, once the arms are abducted, is to adduct them, that is to bring them close to the thorax and anteriorly. This action is accomplished by contraction of the pectoralis, the teres major, and the latissimus dorsi. These muscles are innervated by the pectoral, subscapular, and thoracodorsal nerves respectively. Fibers for this nerve arise from C5, C6, C7, C8, and T1. Next action is flexion of the elbow. As I mentioned before, this action is accomplished by the biceps, brachialis, and brachioradialis. These muscles are innervated by the musculocutaneous and the radial nerves. They receive fibers from C5 and C6. Please take a moment to look at this table. I encourage you to look up these muscles and their innervation in any anatomy textbook for more details. Before leaving the subject of arm force, I'd like to say a few words about grading force. My bias when describing force in a neonate is to label each limb as normal, paralyzed, or weak. Only after having examined many neonates of different postmenstrual age is it that one gets a feeling for what degree of force is normal for the different postmenstrual age groups. After having evaluated force, I evaluate musculotendinous reflexes of the arm. There are three musculotendinous I evaluate. The first one is the biceps. I do this by tapping the distal arm anteriorly. This stretches the biceps. The information from the biceps travels in the musculocutaneous nerve, reaches and gets processed in the 5th and 6th cervical spinal cord segment, travels back through the musculocutaneous nerve and reaches the biceps. This causes a contraction of the biceps. The second arm reflex I evaluate is the brachioradialis. I do this by tapping the proximal anterior forearm over the radial side. This tap stretches the brachioradialis. The information travels in the radial nerve, reaches and gets processed in the 5th and 6th cervical spinal cord segments, travels back in the radial nerve, reaching the brachioradialis. This leads to a contraction of this muscle. The third and last reflex I check in the arm is the triceps. I do this by tapping the distal arm over the back. This tap stretches the triceps. The information travels in the radial nerve, reaching the cervical spinal segment of C6, C7, and C8. Then is sent back through the radial nerve, reaches the triceps, and it produces a contraction of the triceps. Usually, normal musculotendinous reflexes are symmetrical and rather brisk. Nevertheless, I consider their absence as a relative abnormality. The evaluation of the arm contributes to the neurological exam report by providing information regarding the status of the motor system. After evaluating the arm region, I evaluate the leg region. The legs should be evaluated by observation, provoked movements, confrontation testing, maneuvers, and by evaluating the musculotendinous reflexes. The information gained from these methods and from the observations made during the evaluation of the resting posture will allow us to conclude the status of the postural tone, force, and dynamic tone. I will at this point comment on each of these components in more details. I will start by talking about two maneuvers I use to evaluate the passive range of motion of the leg. The first one is aimed at finding the popliteal angle, and the second one at determining the ankle dorsiflexion angle. This picture demonstrates how to perform the popliteal angle maneuver. This maneuver is performed by maintaining the pelvis flat on the mattress while flexing the thigh at the hip. Once in this position, a finger from the other hand is used to hook the ankle as shown in the picture and to pull it rostally. The angle formed by the back of the foreleg and the back of the thigh, as depicted by the yellow arrow, is then measured. This angle reflects the passive postural tone of the hamstring muscles, and its normalcy has to be judged taking into account the post-menstrual age of the neonate. Measured this way, at 28 weeks, the angle should be about 150 degrees. At 30 weeks, the angle should be about 130 degrees. At 32 weeks, the angle should be about 110 degrees. The angle should be about 100 degrees at 34 weeks and at 36 weeks. At 38 weeks, the angle should be about 90 degrees, and at 40 weeks, the angle should be about 80 degrees. The second maneuver I use to evaluate the passive range of motion of the legs with the purpose of determining postural tone is the ankle dorsiflexion maneuver. This maneuver is done by grabbing the foot between the thumb and the index finger as shown in this picture. Once so held, gentle pressure should be applied, attempting to approximate the thumb to the finger. The pressure should stop when enough resistance is felt by the examiner. The angle formed from the dorsal aspect of the foot to the anterior distal foreleg is usually the one measured. This angle is represented here by the green arrow. But we can also measure the angle formed from the plantar aspect of the foot to the distal posterior foreleg. This angle is represented in this frame by the yellow arrow. Regardless how it is measured, these angles reflect the passive postural tone of the calf muscles, and its normalcy has also to be judged taking into account the post-menstrual age of the patient. At 32 weeks, the anterior ankle dorsiflexion angle should be about 150 degrees. The posterior angle should measure about 210 degrees. At 36 weeks, the anterior ankle dorsiflexion angle should be about 70 degrees and the posterior about 290 degrees. And at 40 weeks, the anterior ankle dorsiflexion angle should measure about 30 degrees and the posterior about 330 degrees. At this age, in many textbooks and articles, the measurement of the anterior angle is often quoted as fully flexed or 0 degree. In my personal experience, maybe because I do not press my fingers forcefully enough, I usually get an anterior angle as stated in this frame of 30 degrees and a posterior angle of 330 degrees. I prefer to use the posterior angle rather than the anterior angle. The reason I like to use the posterior angle is because it allows for a better comparison with the popliteal angle. The posterior dorsiflexion angle and the popliteal angle result from the evolutionary process that transforms the four-legged creature into a two-legged creature. I will expand on these comments in the next few minutes. We have said that the examen between 1 day to 7 days of chronological age, neonates born with a gestational age between 28 and 40 weeks progressively narrow their popliteal angle while widening the posterior ankle dorsiflexion angle. The evolution of these angles occur because of the progressive increased stiffness of the hamstring muscles during the neonatal period and the increased flexibility of the posterior calf muscles during the same period. The progressive increase in tone of the hamstring and the progressive decrease in tone of the posterior calf muscles encountered in premature neonate as postmenstrual age advances indicates good neurological maturation and predicts independent and smooth gait. I describe leg postural tone as normal, increase, or decrease based on the evaluation of the resting posture and passive range of motion. Once this is done, I evaluate force. When evaluating force, I initially consider the active range of motion of the legs. The evaluation of the active range of motion starts with simple observation. The aim is to judge the normalcy of flexion, extension, adduction, and abduction of the leg. I like to stress that during the evaluation of active leg range of motion, as it is for the resting posture and active arm range of motion, it is imperative that the head and trunk be aligned. In addition to mere observation, non-specific stimulation of the thorax or the feet may lead to limb flexion and extension. We can also provoke more specific movements by using 3 maneuvers. The first maneuver is very simple. It consists of using a noxious stimulus like poking the sole of the foot with a Q-tip. Poking the sole of the foot with a Q-tip produces a withdrawal reaction, thus allowing us to evaluate leg flexion. The second maneuver is performed by applying steady firm pressure on the sole of the foot when the leg is flexed. Then, while still keeping the finger on the sole of the foot, the pressure is gently withdrawn. The response to this maneuver is for the leg to extend as if being drawn forward by a magnet. The third maneuver I often use to evaluate leg movements is called the cross extension reflex. The best time to provoke this reflex is when the neonate has both legs midway between fully flexed and extended. The cross extension reflex is provoked by holding one leg down and stroking the sole of the foot being held. This action will trigger a characteristic pattern of movements in the free leg. We usually see a brief flexion of the leg followed by extension and adduction of the leg and fanning of the toes. The cross extension reflex has been studied in premature neonates as their post-menstrual age advances. A response limited to extension of the leg after a brief initial flexion is usually present by 32 weeks. By 36 weeks, in addition to the extension, we also see adduction of the leg. And also, at this time, we see fanning of the toes. Following the observation of the active range of motion, the next step in the evaluation of force is confrontational testing. Confrontational testing is evaluated by sensing the push of the leg against our hand or by judging the resistance of the leg to be moved when we apply pressure against the direction of the neonate intended movements. I will take a few minutes at this point to talk to you about the actions, muscles, nerve, and spinal segments that are assessed while the legs are being flexed and extended. I will start by talking about the actions needed to extend the legs. When the legs are flexed and the neonate extends them. Going from the proximal to the distal leg regions, the first action we will see is extension of the thigh. This is accomplished primarily by the gluteus maximus. The gluteus maximus is innervated by the inferior gluteal nerve. The spinal innervation for the gluteus maximus arises from the second, third, and fourth lumbar segments. Extension of the leg also requires extension of the foreleg. This is accomplished primarily by contraction of the quadriceps. The quadriceps is innervated by the femoral nerve. The spinal innervation of the quadriceps arises from the second, third, and fourth lumbar regions. The third major action to accomplish extension of the leg is plantar flexion of the foot. Plantar flexion is primarily accomplished by the tibialis posterior, the soleus, and the gastrocnemius muscles. These muscles are innervated by the tibial nerve. The spinal innervation of these muscles arises from the fifth lumbar segment and from the first and second sacral segments. The final action to achieve full extension of the leg is plantar flexion of the toes. This is primarily achieved by contraction of the flexor digitarum longus and the flexor hallucis longus. These muscles are innervated by the tibial nerve. The spinal innervation of these muscles arises from the fourth and fifth lumbar segments and from the first and the second sacral segments. I would like for you to spend a few seconds glancing at this frame. It summarizes the most important muscles, nerves, and spinal segments involved in leg extension. So let us now see what are the actions, muscles, nerves, and spinal cord segments needed to flex the leg when the leg is in an extended position. The actions needed to flex the legs include flexion of the thigh. Flexion of the thigh is achieved primarily by contraction of the iliopsoas muscle. The iliopsoas muscle is innervated by the femoral nerve and from other branches from the lumbosacral plexus. The spinal innervation of the iliopsoas muscle arises from the first, second, and third lumbar segments. Contributing to leg flexion is foreleg flexion. Foreleg flexion is accomplished by contraction of the biceps femoris, the semitendinous muscle, and the semimembranous muscle. These muscles, jointly called the hamstring muscles, are innervated by the sciatic nerve. The spinal innervation of these muscles arises from the fifth lumbar and from the first and second sacral segments. The next action required to flex the leg is dorsiflexion of the foot. Dorsiflexion of the foot is primarily carried out by contraction of the tibialis anterior, extensor digitarum longus, and extensor hallucis longus. These muscles are innervated by the peroneal nerve. The spinal cord segment serving these muscles arise from the fourth and fifth lumbar segments and from the first sacral segment. The final action needed to achieve full flexion of the leg is toe extension. Toe extension is achieved by contraction of the extensor hallucis longus, the extensor digitarum brevis, and the extensor digitarum longus. These muscles are innervated by the peroneal nerve, by fibers arising from the spinal cord, fifth lumbar, and first sacral segments. I would like for you at this junction to spend a few seconds glancing at this frame. It summarizes the most important muscles, nerves, and spinal segments involved in leg flexion. The last point I want to make regarding force is about grading it. I label each limb as normal, paralyzed, or weak. If both legs are weak and one is weaker, I express which one is weaker and by how much, by simply labeling the weaker leg as a little or a lot weaker than the other. When necessary, I also comment on the distribution of weakness and on the function that is affected. The next component is dynamic tone of the legs. I start this component of the evaluation of the legs by assessing the musculotendinous reflexes. I first evaluate the ankle. I start by tapping the Achilles tendon. Tapping the Achilles tendon stretches the gastrocnemius and the soleus. Information regarding the stretch of these muscles is then carried via the tibial nerve to the first and second sacral spinal segments. In this segment, the information is processed. This process includes incorporation of information from the brain, basoganglia, brainstem, cerebellum, and neighboring segments of the spinal cord. Then the processed signal is sent back through the tibial nerve to the gastrocnemius and the soleus, leading to their contraction. The contraction of these muscles will produce plantar flexion of the foot. Next, I evaluate the knee musculotendinous reflex. This is achieved by tapping the quadricep distal tendon. The tapping of the knee stretches the quadriceps, sending information traveling through the femoral nerve to the lumbar segments 2, 3, and 4. At this location, the local information is processed and influenced by centers from above, and a signal is generated. The generated signal then travels via the femoral nerve, reaching the quadriceps and provoking a contraction of this muscle. This contraction will bring about foreleg extension. The last musculotendinous reflex I evaluate in the leg is the mesial distal thigh. A tap in this region stretches the anterior portion of the adductors magnus and of the gracialis. This information travels via the obturator nerve. Once this information reaches the second, third, and fourth lumbar spinal segments, a very unusual thing happens. The processing of this information leads to excitement of the ipsilateral and contralateral obturator nerves. The signal so generated now travels through both obturator nerves. Once reaching the adductor magnus and the gracialis muscle, they contract. The contractions of these muscles lead to adduction of both legs. Normal leg musculotendinous reflexes are symmetrical and rather brisk. Absence is relative abnormality. In addition to eliciting the musculotendinous reflexes at the ankle, knee, and thigh, as part of the evaluation of the leg's dynamic tone, I attempt to provoke foot clonus by flipping the anterior sole of the foot. Foot clonus is provoked by briskly raising the distal region of the foot as depicted by the red arrows. A normal response consists of no clonus or a limited number of symmetrical clonus. I consider more than 10 symmetrical clonus as a relative abnormality. The final step in assessing dynamic tone is triggering the plantar reflex. The plantar reflex is brought about by stimulating the lateral aspect of the sole of the foot as depicted by the arrow. The procedure to elicit the plantar reflex is at times called the Babinski maneuver. The term Babinski is also used to describe the pathological finding of big toe extension triggered by stimulation of the lateral aspect of the sole of the foot. In neonates, the response to plantar stimulation, as shown in this cartoon, may be plantar flexion of the toes. This response is strictly similar when the opposite foot is stimulated despite minor differences in the pattern of stimulation, or at times the toes do not go down but go up in one foot and then go up in the opposite foot when stimulated. So in neonates, up or down big toe movements elicited during plantar stimulation are normal as long as they are symmetrical. The evaluation of the leg contribute to a neurological exam by providing information regarding movement, postural tone, and dynamic tone. The neurological exam of a neonate is performed by selecting how to best test all areas of the nervous system, such as the brain, the spinal cord, or the lumbosacral plexus. Overstimulation of the neonate during the exam should be avoided. Keep in mind the following dictum. What can be evaluated by observation should not be checked by manipulation. The neurological examination report should be brief, the impression concise and unambiguous. The word normal in the impression indicates the absence of a neurological abnormality and the absence of a significant maturational delay. Thank you.